Somebody was asking, what if you want to do some of this stuff to yourself at home? Well, I think it's a little tough to do an arm or a leg pull by yourself, but if you have something to hold on to, like some people have chin-up bars that they put in their doorway, and I'll grab a chin-up bar that I have in my house and I'll do my own little arm pull by hanging at different angles for that chin-up bar to stretch out, say, my shoulder or my elbow. So if there's something the patient could hold on to, they may be able to get some arm pull traction. Leg pull traction, at certain angles, if you use one of those nice straps, you could lasso your foot and you could go through some of the circumduction, but you don't really get the tractioning effect. So it's not as useful with the leg pull. For the suboccipital release, who doesn't have tension under here? Because so many people have that forward head posture, that occiput is sliding anteriorly on C1 and it compresses that suboccipital space. So if you're thinking, wow, you know, that felt really good in the clinic to have someone do this to me, can I do it to myself? Now, Upledger Institute uses what they call a still point inducer, and it looks like two balls that they put underneath the head. I decided to have a cheaper version of doing that. Take 2 tennis balls, put them in the bottom of an old sock that you lost the other sock, tie a knot in it so the tennis balls are really tight and close next to each other, and as the person is laying supine, or for myself, I'll put the tennis balls right underneath the occiput there. Find that sore spot and then just rest completely flat, and I'll feel my head just sinking on the tennis balls. And once the head is sunk down, just like we did here with the fingers, follow it with a little bit of that nodding, that little chin tuck, just get some range of motion in there and start working on lengthening those posterior cervicals. That's where everybody's so far forward. So 2 tennis balls in the bottom of a sock works nicely. And also the socks, if it's up against a cloth sheet on your table, are very nice because it doesn't slip easily. So I've actually bought some of those still point inducers and I found they just slip slide all over the place unless you put Velcro on the bottom. So that's a quickie thing. Another thing you could do, which if she was my patient, if she had strong fingers, and I do this to myself to reduce the tension, put your fingers underneath your own occiput here. So say your middle finger and relax your arms. And then come down below the occiput, and I show the patient right where that C2 is. So come right across here with a finger or two from each hand. Now if you can straighten out your fingers, so go from bent to straight so your head picks up when you're doing that, and then just let your head sink down on your hands. And I do this without a pillow. I mean, she's on a hard banquet table, not a treatment table, but I'd have the head just sink down into her hands, and at the end she could do some of that nodding chin tuck movement to start opening it up. So I'll just spend that 1.5 to 2 minutes, the fingers back there, let the head sink back on them, and then follow it with a little bit of flexion. Easy to do. So I show patients how to do this all the time. They like the tennis ball because they don't have to use their hands. Some people can't even get their arms up that high to use their hands. And you notice if your hands are a little weak, this was a killer for you, wasn't it? Correct. Do some exercise. Get that TheraPutty and work with the putty and the soft balls and all the various, you know, your exercise equipment. Get your fingers strong. That's especially for your lumbricals and extensors of your IP joints. You want to get those to go. Sometimes just practice coming in like this. Flexion, extension, lift the head. As the head lowers, I pull and traction. So remember there's 2 steps. One is letting the head sink into your palms because your pressure on the tendon relaxes the suboccipital muscles, relaxes the neck extensors, so the head just drops in your hand. Then you have to follow with that flexion. So that's it. You can certainly do it at home, either using tennis balls or something. People sell all kinds of tools for these things. But tennis balls in the dollar store, I get 3 for $1 in the doggy section. And I put them in the bottom of an old sock. So you save a few bucks. That's a great question. Thank you. So if you're having trouble feeling this, the first day I was doing these techniques when I took my first course, I didn't feel a thing. I thought, what the heck is wrong with me? I feel nothing. I was so tense in my own body, I couldn't feel the patient's tension. So A, you need to have yourself biomechanically in a good position so you're not too busy attending to your own tension, you're attending to the patient's tension. That's number one. Many people will be here and they have the hands on the body with the fingers flying around in the air. You want the hands conforming to the body part. Rest those fingers when you put the hand on the body. Rest your hand. Take the tension out of yourself. If you're so tense, all your pressure receptors get obliterated. If you're pushing too hard, your pressure receptors get obliterated. You know, you have your Ruffini nerve endings, your Pacinian corpuscles, all those things in there that tell you about size and shape and pressure. You need to have your hand relaxed for that to work well. I'm going to relax my hand in the body. I'm going to tune into just his breathing because it's so obvious. If it's not that obvious, I'll tell him, hey, take a few deep breaths. I really want to feel your body moving here. And once I get the sense of the breathing rhythm, that's somewhere between 12 and 20 times a minute at rest. I'll follow it, let my hand float up, let my hand sink down, and just get a sense of following the tone difference from the diaphragm contracting and relaxing, breathing. Now after you do that, you just continue resting your hand there. Do you notice that as he's breathing, is there anything that feels like it's kind of pulling your hand this way, that way, any way around an imaginary clock? And where you sense like that tone shifting, follow the shift in the tone, because that's all it is. It's a change in muscle tone, fascial tone. Follow that change. So for him, I felt his tension was pulling up toward his left shoulder and then coming back to the middle. Up toward the left shoulder, that was his sway pattern in the fascia, and back to the middle. So I followed it just with very slightly kind of easing my hand up toward the left shoulder and back to the middle. And I found that pattern and identified that pattern, and it was half the speed of his breathing rhythm. Bang, craniosacral rhythm, 6 to 12 times a minute, which is half the speed of the breathing rhythm. So it's the slower rhythm or slower motion in the tissue that you can sense with your palm if you close your eyes and you really make believe you're looking through your palms, you're listening through your palms, you're feeling everything through your palms. So your attention is entirely present here. Not off, did I feed the dog today? Not off, they're not playing the song I like on the radio. Not off, oh, what do I have to do with the patient next? No, I'm here now. And I'm attending and concentrating. And then I'll follow that sway pattern until it stops. Now, if you just left your hand there and kept following it, you could go on and on for hours. I follow one or two of the sway patterns, which direction, clockwise, counterclockwise, where does it pull my hand? And at the end of one of those patterns, either for him it was up to the left or down to the right, I'd follow that pattern and then lock my hand there. So I say stopped up to the left, I hold that pattern in a still point. It stops moving, everything shuts down, becomes quiescent. And you wait, and you wait. And there's no pattern, there's just the breathing. There's not that other little tension change you were sensing in there. After about 1.5 minutes to 2 minutes average, all of a sudden you're going to feel like the tissue's kind of pushing and nudging your hand a little bit, and then you follow and allow a new pattern to engage. And that's essentially the release. You're inducing a still point, that's what it's called. Identify the pattern, follow the pattern's tension with your palm, stop at one end of the range of motion against the barrier to that pattern. Either one, doesn't matter. Sometimes you call it direct technique or indirect technique. Direct technique, we went in the direction of tension. We went against the barrier. Indirect technique would go in a direction of ease, the way the body moves easily away from the barrier. Either way will work in craniosacral therapy. Either way will work. Follow the pattern, stop the pattern, still point, 90 seconds, 2 minutes, whatever it takes. Sometimes I've spent a few more minutes. Sometimes I've felt it release it quicker. But it's documented for over 60 years in the clinical literature, average of about 1.5 minutes. And find a new pattern. And I'll do typically 2 or 3 still points in a given area and check and see if I was doing his respiratory diaphragm, maybe his breathing change, maybe his rib excursion or trunk range of motion change, maybe his functional reach of his arm change. So the key is, these are subtle things. You need to do some kind of measurement pre and post treatment to make it really obvious that you have noticed that change. And I have patients who say have asthma, breathe better with this. Somebody had indigestion and gastric reflux, relaxes that area around the gastroesophageal sphincter. Okay. People who have anxiety issues, lowers anxiety disorders. This is noted in the literature. So these are things that you can tell. So I'm just kind of wrapping up those transverse planes. Do you need a few more minutes with the transverse planes? Okay, go ahead and take a few more minutes, practice. If you're doing this as a home study, you need to have somebody on the table and practicing with them, especially if it's a fellow clinician. Get together with your fellow clinicians. Okay? If you're a boat on a river, you got plenty of Great Lakes here, right? You have currents in the water. So there's a kayak floating down the river with nobody in it. Where is it going to go? It's going to follow the motion of the current in the river. Your job is to detect the motion of the current, the change and tonal tension in the fascia. And make believe your hand is like a kayak floating down the river with nobody in it. It's going to follow the tide or follow the current. You can follow the current or the tide of the fascial tension as it shifts in the body. And that has a lot to do with giving up control. What are we taught as practitioners? Fix that lesion, make this happen, manipulate that joint, move that frozen shoulder. So you're action-packed. You're going to make something happen. We're not doing that here. Here we are inviting the tension to change, so we're facilitating. Think back to those of you who learned about neurodevelopmental therapy, where the handling and where you touch patients has a big difference with their movement pattern. This is a lot like that. You need to sense the movement pattern, which is the subtle changes in tone in the myofascial system. Follow those changes in tone. It almost feels like when we did that bioelectric palpation exercise. Feels like a magnet, pulling your hand this way, pulling your hand the other way. But if you close your eyes and picture my hands like that kayak on the river, which way do I feel the river of her tension moving? Can I follow that to an end point? Because there's always a pattern where it goes from one direction to the opposite, one direction to the other. Stop at either end of the range of motion or either end of the barrier. Wait, hold it for the still point, the minute and a half or so. Wait for a new pattern to emerge. And that is when you disengage your hand. Oh, there's a new pattern, good. Hopefully it's more resourceful than the last pattern. Okay, and we do 2 or 3 releases in a given area. I hope that helps. Close your eyes, feel through your hands, relax your body. And the more comfy you are in your setup with the patient, the better. When you're doing these transverse plane releases, that's the perfect time to teach your patient the deep breathing exercise. Because they like to have something to do. If they're the kind of patient who relaxes on the table and falls asleep, fine. They could sleep through it if they want. But for everybody else, it's rolling their eyes going, what are you doing? Yeah. Why do I have to wait here? I don't feel nothing. You know, this business is going on. I say, okay, I'll tell them, focus on your breathing. We're going to do a relaxation exercise to help your breathing. And it's a perfect timing for you to go ahead and sense the craniosacral rhythm and induce a still point and change the pattern. Get them a more resourceful pattern. Meanwhile, they're busy focusing on their diaphragmatic breathing. So whether you tell them, picture you're out on a boat in the lake, or if you like the woods, picture in the woods by yourself and you're comfortable and you're breathing and everything's so relaxing. And that helps also to lower that sympathetic tone that people have in such excess. And it keeps them busy while you're doing your work. And I'll tell a patient, you know, this is a quiet technique. If something's uncomfortable and you want me to, you know, change my hand position, I'm pulling your hair, or you need to move, that's okay. Just tell me, speak up. Otherwise, you're quietly breathing and focusing on what you feel in your body. Let's talk about what you feel in your body here. Let's tune in to what's happened in this area that you had this injury. Let's get you to tune back in here. You tuned out since you had that cast on for 6 weeks. Let's get you to tune back in so you move better. You move with more efficiency, more grace, less pain. And this is what I'm explaining to patients as they're going. I'll give them patient education. They're very receptive at this moment. Perfect time. Talk about their ergonomics. Talk about, think about going for a nutritional consult. If you think that's the issue with the patient, it's time for you to talk. You're busy, they could listen. So it's great stuff. How you doing? What's your name?
Susie.
Susie. Now, before you work on somebody, we're going to be touching people's face. So what do you want to do? Clean. Hand sanitizer, wash your hands, whatever it is. Make sure nice and sanitary. Okay, so we're looking at the skull here. We're going to do a temporal release, temporal bone. So temporal bone, actually it's easier to see on the colored side of the skull. That's housing the ear. So you think about the external auditory meatus, the mastoid process. Okay, that's temporal bone. Coming right up around where you see the red. And what muscle attaches to the temporal bone? Temporalis. Easy. It's one of your clenching muscles. So clench your jaw, open and close. Yeah. How many people are chomping at the bit? Right? They have bruxism. They might be chewing and chomping at night when they're sleeping. So that temporalis muscle closing the jaw. And sometimes people get headaches from this. Temporal headaches. So you want to be able to use the ear. We're going to use the pinna of the ear as a little lever to pull on the temporal bone and decompress the temporal bone from sphenoid, frontal bone, occipital bone. Kind of open up the bevels. Now this is actually not a real skull, it's a model, so They didn't do such a great job on the sutures, but the sutures come up in a C shape around the ear. So if you feel on the patient's head for now, feel on your own head. So I'm going to be poking you around the head here. The ear is housed in the temporal bone. If you feel behind the ear, that lump, that bony prominence that extends caudad from the ear posteriorly, that's the mastoid process. What attaches to that? Sternocleidomastoid, neck flexor, side bender, contralateral rotator. One of the things that happens, this is a very strong neck flexor, and it gets short when people are in what? Forward head posture again. If there's an abrupt strain to the sternocleidomastoid, blow to the head, a slip and fall, a whiplash, it tends to make the SCM very tight, and when that pulls on the mastoid, it tends to lock up these sutures that the temporal bone goes into. So we like to do what we call an ear pull or temporal bone decompression. And that is, any problems with the ears I should know about? Okay. I like to hold not on the outside of the ear because it's too squishy. You know, the ear has cartilage and a lot of skin around the outside, but more the firm cartilage. So I'm not going to jab my thumb into her ear, but just feel the pinna of the ear and the firm part of the cartilage here. Now feel this on yourself. We're going to do a little range of motion. So grab your ears on both sides. Very gentle. How hard am I squishing you, would you say?
Not very.
Not very. So just what is the lightest pressure you could use and still get a good purchase on that tissue you're holding? Right? You don't want to hurt anybody's ears. So I'm just pinching between, say, my thumb and index finger, and I'm just going to see if I pull her ears directly posterior toward the back of the head. Oh, on her, the right ear feels tighter. You can sense that? Feel it? Now I'm going to go anteriorly, so I'm taking my index finger underneath, pushing the ear a little forward. But that backward is much tighter. Now how about up and down? So superior glide of the pin of the ear. Also the right's tighter that way too, feel?
I don't feel that one as much.
Not as much, but it is there. Inferior glide. Plenty of motion on her for inferior glide, but the right one stops before the left. Can you feel that? So her limitation is inferior glide, posterior glide. Feel where your limitation is. Everybody's different. We're fine-tuning to every individual's barrier. Now the general release to decompress the temporal bone along the temporal parietal suture is a very slight traction of the pinna of the ear, posterior and lateral. Lateral meaning away from the body. I assume you remember your cardinal planes. If not, you really need to look a few things up. So posterior toward the back of the head, lateral away from the head, side to side. Feel that tug? And what does that feel like in your ear?
Not much.
Not much. Patients who have significant restrictions here will often say things like, I feel like there's a feather in my ear tickling me. Oh, I feel postnasal drip running down my throat because it clears some of the eustachian tubes. But people might have some sinus pressure, some congestion. Some people say, you know, there's that ringing in my ear. Or I had a ringing in my ear and now it changed. So there'll be a change of something, and a patient with significant limitation here will sense it. She could sense the tension, but nothing really significant beyond tension, which means you're probably a little healthier. So that's worth a try. And we take up the slack and hold, and you're back to that 1.5 to 2 minutes or so until you feel a softening. And then you can release and repeat that process. You can do 1, 2, 3 releases. And how much time do you have to spend with the patient? If ear problems, sinus pressure, vestibular problems were her issue, I might end up spending more time here if I believe those problems were due to myofascial tension. Now you feel how it changed there? Now we're going a little bit inferior and lateral instead of out, away from your head and lateral. There you go. So now she got a little release, so I'm going to let that go. So easy to teach a patient to do this on herself. If I have patients who have tension headaches, temporal headaches, cervicogenic headaches, problems with the ear, sinuses. Oh, I always feel like my ears, I have to, you know, they do the yawning business, they're trying to pop them. Oh, I have a problem in the plane, I have a problem diving, problems with tension and pressure in the ears. This is often very helpful. And if they've had whiplash or blows to the head also, I'm going to do the general cranial releases that I'm showing you today, all of them to try to balance the tension in the cranial system. Now let's just check her range of motion again. So after you did a little release on yourself, Check again, a little posterior glide. Feel any different? Anterior glide. Inferior. Superior. Feel same, different, or don't know?
My left one seems like it stretches further.
Yeah, her left one feels like it stretches further because the right side on her is more limited. And we noticed that from the very first time I just tested. So using the pinna of the ear as a handhold or an anchor for us, we're working on decompressing temporal bone from the sutures. What goes nicely to do with that, of course, what do we call this joint here? Temporal mandibular joint. So this is where the mandible articulates at the temporal bone, so TMJ. So open and close the mouth for me a couple times. And her TMJ bulges, her mandibular condyle bulges on the right side considerably more than left. Feel that yourself. Put your fingers here. And I show my patients, when I feel something asymmetrical, I show them. Feel this on yourself. I want them to tune into what's happening with their body. Right? Feel that one pops out? So she's actually subluxing on the right side. Maybe that has something to do with the tension. You know, you'll see patterns when you start looking at these things together. So we're going to do a compression, decompression of the TMJ using the mandible. So if we're lining up the head where she is, the mandibular ramus is the flat part underneath the cheekbone. So get your finger pads, and I like to use my pads like my fingerprints underneath the cheekbone, right on the ramus of the mandible. Can you see okay? And we're going to compress. To compress the mandible, we're going to do like a superior glide, pulling the ramus up, meaning superior. And then an inferior glide or a decompression, pushing that pubic ramus down, meaning toward the feet. Now for the compression, I like to be a little more on the angle of the mandible here, so I have a little hand hold. Compress slightly. Wait for a still point, a minute and a half or so, and then fingers right flat on the ramus of the mandible, decompress. So straight inferior glide, if you will. The decompression opens up, and I'm just exaggerating here in the model. Obviously, you don't want the patient moving that much, but you're just kind of decompressing that mandible to open. Because so many people hold tension, what are we always doing? Closing it. The masseter muscle comes in here, closing, and of course, temporalis muscle. And that's what you're seeing here, masseter, temporalis attachments. So of course, if they have TMJ problems, it's an absolute must to be checking out this compression, decompression. Anything in the mouth? Now I like to make sure they don't have anything in their mouth because A, I don't want them to choke laying down, and B, if they have something in their mouth, even if they say, oh, I'll just tuck the gum in on the side, they're holding tension in the jaw. So just relax. So here's the angle of the mandible. You're going to feel a slight pressure of me pulling your jawbone up towards your head. It should not hurt. If it hurts, I need to know, okay? That's the thing. If you're giving them pain, they might have, there's a little disc, okay, fibrocartilaginous disc in that TM joint. And if it's fragmented or torn and you compress it, they might get a very sudden, sharp pain. So everything is done gently. I'll assume you have examined the TM joint before you're doing any of this. So you just feel a little pressure. You can just rest your eyes, close your eyes. Now, as I compress up, I notice the whole right side of her jaw is elevated compared to the left. It's actually hiked up. I don't know if you could feel that. Feel any difference in pressure in your jaw joint up here when I'm doing this? You okay with that? And it's hard for people to talk when you're holding their jaw closed. How much pressure would you say I'm putting on you?
Very light.
Very light. She can talk. So here's the point. If the patient can't speak because you're jamming their jawbone closed, you missed the boat. This is very light. So I'd wait for that compression, get a little still point, about 90 seconds, and then decompression. Now I'm coming up a little above the angle of the jaw, but below the cheekbone, the zygomatic arch. And now we're going to decompress by a straight inferior glide. So I'm pushing that way toward the feet. Now what am I working through here? The face. What attaches into the skin on the face? Very different than anywhere else on the body.
The mandible.
The mandible. Muscles. Yeah, everywhere else in the body, the muscles attach to like bones or aponeurosis or something. Here, the facial muscles attach into the skin. That's why we have facial expressions. So really gentle when you're dealing with someone's face. You don't want to give them a new face. So you feel that little bit of tug in the jawbone, both sides? So it's just a straight decompression, and I'd hold that until it's softened. And it's a wonderful reduction of their headache if it's caused by clenching the teeth, which many people do. Bruxing at night. And if they're uneven like this, you think it would be a great idea for her to see a dental specialist who works with TMJs and might check to see maybe her teeth are uneven. That's called malocclusion. That might be making the jaw go out of alignment. Maybe she needs a filling in a tooth she let break. Right? Maybe her teeth are crooked, need to be adjusted. You know, any number of things. Maybe years ago she was playing sports and got hit in the face with a ball. And it tended to put her jaw off center, but because she was young and she compensates real well, it was fine. And then years later it's starting to tighten up and she doesn't know why. And these are common things. What are you thinking?
16 stitches in my chin when I was 16.
16 stitches with her in her chin when she turned 16. There you go. So you'll find people will start to remember things. Oh yeah, that was that. And I feel that just loosened up a little bit right there. And she can feel the release. So what do? I point it out to the patient. Oh, did you feel that relax right there? Oh, did you feel that move right there? Because we want to make sure that she tunes into this as well. Very soft open and close of the mouth. Open, nice and easy. Nice and easy. I don't have them open so wide that they're popping out. I did that once to examine and just see, and I'll do that again once just to see here. To open big. Good. You feel that lurches out that way? Yeah. So this, we're going to start working on that. This would be very helpful for that. Thank you so much. Come on up slowly. So whenever I do these techniques, I have the patient engage some of those motions by actively contracting. In this case, the jaw. I might say, open and close your jaw. Bring your jawbone side to side, extend, flex your head. Have them start to use some of those new motions so they start to incorporate it into what they're doing every day, right? So go ahead, get a body on the table. Thank you. When you're looking at the TMJ compression, decompression, people are asking, well, do I have to use my fingertips? Can I use my palm? Whatever engages that tissue is fine as long as you're comfortable. I like to use my fingertips where my fingerprints are because they're soft and they feel comfortable for a patient. And I have a lot of sensory receptors in my fingertips. So I can really pick up on subtle changes in tension with those fingertips. And I often feel like as I compress the TMJ, compress the mandible, it's almost like closing a drawer. You ever try to pull out a dresser drawer and it's just stuck and it's kind of crooked and it feels like it's latched on one side? Well, if you close the drawer first, you ever notice it unlatches and you find it smooth to open? I think of this TMJ compression, decompression as closing a dresser drawer and then opening the dresser drawer, kind of like unlatching it, and it slides open on both sides. So if that gives you a little visual about what it feels like, I hope that helps. I try to ask myself from a clinical perspective, what is this patient's greatest limitation? What is most disabling to my patient? That's where I'm going. Protocols are interesting. They're a nice way to start to learn things. But I think if you're treating a patient and you want to start incorporating these techniques, I'm giving you enough techniques that you have something to try and play with. But if you have someone come in and it's a headache issue, well, is it more a frontal headache, temporal headache, or an occipital headache? Occipital headache, maybe you want to do the suboccipital release first. Temporal headache, and you know that they clench their jaw a lot, maybe you want to do what we just did. TMJ decompression and an ear pull. To kind of look and see what is most restricted on this patient. When we did our general and local listening earlier, we tried to see where is the greatest fascial tension showing up in terms of their body sway. Maybe I want to treat that first. So it all becomes part of the whole clinical picture you have when you're evaluating a patient. Okay, so for a frontal lift and parietal lift, frontal bone, that's basically our forehead coming up into our coronal suture here. Can you see okay? So coronal suture, where the crown would sit, say if you were the queen of the castle, you wear a crown over there. Frontal bone coming in, connecting into sphenoid bone. So a lot of people with, again, the clenching, there could be eye problems because the frontal bone is articulating here, creating the upper limits of the orbits of the eye. So if somebody had a blow to the head, smacked their head, maybe they fractured part of their orbit, they may find out now they're getting a lazy eye because the attachments of the muscles are uneven. And I've worked on patients who had lazy eye and years ago it had traumas, and it improved that. So that these are different things that you could think about. What's embedded here in the frontal bone? Sinuses. How many people have sinus irritation? So this is a nice area to work for a lot of that. So we'll just put that aside. Now, frontal bone is a singular bone, so when we're describing from a craniosacral perspective, flexion would feel like a widening, extension feel like a narrowing. So flexion, widening, extension, narrowing. When we do the parietal bone next, parietal bones come as a set of two different bones on both sides of the head, separated by the sagittal suture. When we're talking about paired bones or two arms or two legs, we're talking about flexion as a widening, extension as a narrowing. Flexion as a widening, extension as a narrowing. Remember that DeLorean car from that show years ago, Back to the Future? I saw a new Mercedes had wings like this too that came up. And that's kind of how the parietal bones move, like DeLorean cars, doors opening up. So let's look at the frontal bone first. Nice place to get a grip. If you come follow the eyebrows, I like to get my fingers just above the eyebrows. Do not be back on the temple. If you feel on yourself. In the soft spot of the temple, that's the sphenoid bone. You want to be superior to that and anterior, so frontal bone. Now I'm just going to rest my fingers here, and as she's breathing, gee, I wonder if I could feel her breathing. Feel it on yourself while you're sitting around watching. A highly sensitive hand can feel the breathing just about anywhere on the body, because there's a widening and narrowing in the body with breathing too, but it's double the speed of the craniosacral rhythm. So as I'm resting my hands here, it's easy when you're sitting at the head of the table to see the rise and fall of the belly or the chest while the patient's breathing, so you know what the respiratory rhythm is. I can see it with my eyes, as well as feel it with my hands. Now, as you're resting your hands here, you're feeling for a sense of widening and narrowing of the frontal bone, half the speed of the breathing rhythm. And you want to rest your hands. Sometimes I just rest my thumbs in the middle. Rest your pinky. How many people like to work like this? They got the dainty pinky hanging out. You ready to have a cup of tea or something? No. Get the fingers down. Just resting. But the fingers operating of the second, third, and fourth digit. So I'm just waiting, and usually the frontal bone for decompressing, you feel like it's moving up and forward. So superior, anterior. Sometimes I'll just put a slight little facilitation. You barely see the fingers moving. And remember, you have to get through the skin and the muscles below the skin to eventually get through the fascias that attach into the periosteum of the bone, into the cranial bone. Anchors for those dural membranes. So I have a little frontal lift. I'm just bringing my fingers a little bit anterior and superior. Forward and up. Comfortable?
Yeah.
Yeah. Patients, it's best for them to just rest with their eyes closed. I like to tell them, think about your jaw, resting position of the mandible. Have your teeth slightly apart, so not that they're holding them apart, but resting apart. The tip of the tongue should be behind the top two front teeth. Okay, that's a resting position of the jaw. How many people, the heads are back, the jaw is agape, or the heads are forward and the jaw is slammed shut? Notice I have her neck in neutral. Her face is facing forward, anteriorly, not looking down, not looking up. So sometimes I'll put a little neck roll behind their neck to give them support if they need that, especially some of my elderly patients. Now there's a little shift of tension here, so I'm doing a lift. Could you feel that shift of tension or no?
Yeah.
She could sense it too. So some patients don't feel anything because they're just not attending. They don't know what they're supposed to feel. If I keep pointing out to them what I feel, eventually they'll start to get that sense. You feel it was a little ratchety right there for a minute?
Yeah.
It was almost like kind of sticky on one side, sticky on the other, and then got smooth again. Again, there's nothing to see. It's all about feel. So say you got to release. I'm going to gently disengage my fingers. And notice I didn't leave any fingerprints on her face. This is very light touch. Dr. Upledger would say the weight of a nickel. Some of my direct cranial osteopath friends, they're in there and it's more like they're physically manipulating the bones. They're more heavy-handed. So there's different styles of cranial. And we're just showing you a more gentle style. You can learn other styles later. For the parietal lift, a good place to look to find the parietal bone would be just above the ear. and above the temporal bone. So we did the temporal bone already. Parietal bone would be, here's the coronal suture, sagittal suture, lambdoidal suture, coming around. So this is parietal bone. It's huge, and it's bilateral. So my hand hold is, there's the external auditory meatus, the hole in the ear, come above the ear. If you feel this on yourself, please palpate by your ear, no snoozing. Find the hole in your ear. Glide your fingers above your earlobe and feel the side of your head here. You could feel on yourself if you want. There's an elevation, depending on the size of your head and your suture, maybe an inch or two above the earlobe. And you can feel that elevation. That's the temporal parietal suture. You want your fingers to be above that ridge. It's almost like a little mountain ridge. Above that ridge, so you're up here on the parietal bone, not down here on the temporal, above there. So we're going to sandwich that parietal bone on both sides with our fingertips, like so. That's what it would look like on the model of the cranium. Let's see what it looks like on our real life person. And I play with the hair to get the hair out of the way, so you're going to feel some pressure on the sides of your head. So here's the ear. If I kind of rub along the side of her head, can I feel? There's the ridge. That's a temporal parietal suture. I want to be superior to that. It almost feels like the patient has a little cap on top of their head, and you're just going to slide that cap off. It feels almost like you're slipping off their hair. So I'm just going to rest my fingers here on either side. You okay with that? Mm-hmm. And I wait to feel the narrowing and widening. So with the parietal bones, it's almost like a clamshell, opening up with the hinge in the middle at the sagittal suture and closing. Opening the clamshell, closing the clamshell. So the opening, flexion, the closing, of course, extension. So palpate yours along with me or somebody else's if you want. And if it's difficult to feel, ask your patient, take some deep breaths and identify once again the respiratory rhythm. So I'm looking down at her belly and seeing, gee, do I feel the widening and narrowing from her respiration? That's going to be twice as fast as the widening and narrowing of the cranial rhythm. And you need to be quiet and focused to do this. The more often you do it, you'll get it immediately. And so you know, some people's amplitude, or the amount that those bones move, we call it the amplitude of motion, is very small. And it's very hard to feel. Some people don't have a lot of vitality behind it. Other people, you put your hands in there, you said, wow, I really felt it on him, but I didn't feel it on his friend. You know, and that you'll feel that difference between people once you start feeling this on different people. Now in our friend here, her right side flexes or widens greater than the left side. Why? I have no idea. That's just what I'm observing. So I don't always question what I observe. I might want to tie it together with her other clinical presentations. Oh yeah, that's where I lean my head on the pillow every night, and I never lay on the other side. People will tell you different things. So follow the widening and narrowing. For the parietal bone, as it goes into its narrowing phase, follow it. Meaning you feel it narrow, and I kind of almost squish my fingers into it a little bit, ever so softly. How hard am I pushing on you, would you say?
Fairly light.
Fairly light. So light pressure, but I'm in the narrowing phase. I followed that flexion, narrowing, and I'm not going to let it widen. I lock my fingers where they are, not by pushing harder, but just becoming with my intention an immovable force. So as her skull bones look to widen in the parietals, again, I'm not allowing them to. That gives them a little facilitation message. Okay, time to reorganize your tension, and you'll induce a still point. What's a still point? It's facilitating the body to reorganize its tension. That will happen intrinsically in the body. And you hold that until the pulse starts again. Patient may or may not feel this. It's okay. Not that important they feel it, important that I do. And then I know how to compare it by feeling it on lots of heads. And it's very still right now. Nothing's moving at all. Any questions while we're waiting for her to kind of get her engine started again here? Okay, so why don't you go ahead in groups. One key issue, if I'm in the middle of a release and I didn't feel it release yet, I don't just jump off and go do something else. I wait until the still point is over, then I can withdraw my hands. Don't withdraw in the middle of it. You tend to leave somebody wondering where they are in space in terms of those joints and sutures you're working on. It's slightly imbalanced there. Everything just shifted there. I don't know if you could feel that or not.
For me, it felt like a nervous twitch almost. Like
Felt like a nervous twitch to her. Do you still feel a nervous twitch, or is it different?
No, it's different.
Yeah. Sometimes they'll feel that. They might feel like they twitched, or they're ratcheting, or it might feel like a very quick passing whooshing feeling. It's different feelings to people when their tension changes. And then that's a good time. Once that shift changes, then I can withdraw my hands, and I may have her follow with some exercise or some other activity that's appropriate for the dysfunction she presented. So let's go ahead and try frontal lift and parietal lift. Anytime with lab, if you need a break, just go ahead and go. Okay? Thank you so much.
Thank you.
Now for the sphenoid release, the sphenoid bone is actually very important. It's called the keystone of the cranium. So if I open up the cranium here, see how there's almost a butterfly shape in the middle of the cranium here? That's a sphenoid bone, shaped like a butterfly. Okay, toward where the orbits of the eyes are, so if you look here, the soft spot in the temple, that's a sphenoid bone. That's called the greater wing of the sphenoid. That's the one spot you can access with your fingertips to facilitate some motion of the sphenoid bone. If you're looking back into the cranium, this is the sphenobasilar synchondrosis, where the basal part of the occipital bone, meets the sphenoid bone, right in the center. Guess what sits in that area? Yeah, your master glands, right? You got pituitary, sella turcica, right? Hypothalamus is in that area, so a lot of master glands here. These bones, I mean, this is a plastic model, but the bones basically move at that axis of what's that sphenobasilar synchondrosis, almost like a clamshell. Widening, narrowing at the occiput, lifting front, greater wing of the sphenoid. So that's where we're going to get a little handhold at that greater wing of the sphenoid on both sides and see, can we do a sphenoid compression, decompression. Okay, if the patient's neck is in neutral and they're comfortable like that on the table, I don't need a pillow roll, but on so many people, if they're very kyphotic, you might find they're more comfortable to be up on a wedge with a little pillow roll underneath their neck. So I like them to be in neutral. If you come in to find the sphenoid, it happens to be right near where that temporal artery comes through. So come just outside, lateral to the lateral canthus of the eye, the edge of the eyeball. Come posteriorly to that. You'll feel a soft spot. And that's where the greater wing of the sphenoid, or the tip of the sphenoid, comes more prominent for you to palpate. And you could use whatever fingers you want. I could use my index finger. I could use my middle finger. Some people come across, because they have a wide hand, if the patient has a narrow head, with their thumb and middle finger. So find that soft spot behind the orbit of the eye. And sometimes you'll feel a pulsation there, so don't squish it really hard. That's a temporal artery. Now the compression will be just gliding that greater wing of the sphenoid down toward the table, and that's closing the sphenobasilar synchondrosis. So my motion is posteriorly, directly posteriorly or toward the floor. The decompression will be an anterior glide, or an anterior movement, decompressing that occiput where it meets the sphenoid, sphenobasilar synchondrosis. So find a spot. Sometimes I could use 2 fingertips, or I could use just a fingerprint, whatever fits in there in that individual patient. Little kids, little tiny sphenoid bones, I'm using my fingertip. So I'm just rest your finger there at first, just to get a sense of motion. Especially when you're first learning to do this, take some nice deep breaths for me. Feel the motion of the head. And I could rest my other hands on his head, just touching lightly. And as he breathes in, can I feel his head moving towards me? As people breathe, the whole head moves. Respiratory rhythm. I could watch the chest and stomach to see how much does he breathe, how many times per minute. What's his rhythm of the respiratory rate? Is that the same rhythm I'm feeling up in his head? That's respiratory rate. Cranial rhythm, again, is going to be slower than that, so if you tune in step by step, you can feel that sphenoid moving. Now, it's going to be a little confusing for some people, because you'll be busy saying, but I feel the temporal artery pulse. Well, that's going to be about 60 to 100 times a minute. That's a completely different kind of rhythm. So try to identify there are different rhythms superimposed upon one another in the body. For the compression, I'm going to very slightly, a tiny little pressure with my fingertip on the greater wing of the sphenoid, And as I'm feeling that dropping down toward the table or posteriorly, I'm going to glide my fingers posteriorly, taking the skin with me. Not gliding over the skin. Remember, the skin's connecting to the muscles of the face, ultimately down into the periosteum of the bone, ultimately anchoring into those bones to give me a nice little handhold. So I have that compression. I'm going to hold that, induce a still point. Hold that compression for the 90 seconds, 2 minutes, whatever it takes. And we'll wait. And that cranial rhythm is half the speed of the respiratory rhythm, so you feel that lifting and lowering underneath your fingers, anterior and posterior. That's the sphenoid. Sphenoid has 3 axes of motion. We're not going into them today. We're just doing a direct compression, decompression. But it has a lot of other motions, side bending, rotation, that have been documented. So you could go crazy taking a whole lot of craniosacral courses and really get involved in all the 3-dimensional types of restrictions that are going on. How are you doing there?
Good.
What are you feeling?
Just like gentle pressure, I guess.
Gentle pressure. So I'm decompressing now and gliding my fingers anteriorly and holding. He's a lot more symmetrical than the patients I've had my hands on recently, so I'm actually kind of delighted that I'm so used to feeling this being more off kilter and imbalanced. His is a little bit more restricted on the left, but not a huge imbalance, so that's kind of nice. It's a treat for me to feel something normal for a change. You treat so many people that are stiff, and all of a sudden you treat an athlete like, hey, it's a big difference. So you feel just that little drawing forward, comfy?
Comfy.
And I just have them work on their deep breathing. This is a good time if there's things you wanted to explain to the patient about their home program or something, and what they can do to help themselves. This is a good time to discuss that. So I'm holding that through the still point. When the still point's over and I feel the motion starting again, I'm going to gently withdraw. So we ease into all these motions and we ease out of all these motions. So that's a sphenoid compression, decompression, very much like the masseter, right? Coming in with your fingers over the masseter for the mandible, compression, decompression, but the direction is different. The next one is actually probably the best represented craniosacral intervention in the literature, and that's called a CV4. CV4 is short for cerebral ventricle number 4. They named it that because the theory is that the 4th ventricle is drained by pumping of the occiput, because it's coming down posteriorly in the head. So on the 4th ventricle, we're going to actually be mobilizing the occiput. I like to put my hands together. You can do this on yourself. If you're not comfortable with your hands like this, it doesn't have to be like this. It's just a suggestion. There are many ways to do this. I cross one palm over another, so my fingers are crisscrossed. I can see my palms, and I put my thumbs together. And now if I do that with my arms flat on the table, let me just get that camera back a little bit for you. I do that with my arms flat on the table right next to each other. I have my palm to palm at the ulnar border, thumb to thumb, so I'm giving myself some stability. If I put my palm right under the occiput like that, it feels like the occiput, and I'm exaggerating obviously, widens and narrows. Flexion, extension, widening, narrowing. It's almost like the occiput's going to be pushing against my thenar eminences, where I'll have the occiput resting on my palm. So if we had the skull, well, if you can bring the skull back, I'll show you on that later. So I'm going to get my hands underneath his occiput and just rest your head there. Now, don't have your patient's head way up in the air like this. Allow the head to go down. So neutral at the neck. The back of his occiput, okay, right along for him, the nuchal lines and a little inferior to those nuchal lines, the bumps in the back of the head, just resting on the thenar eminence of each of my palms. And I'm just going to let him rest there. I'm keeping my palms together and holding, making like a little pillow for his head. And I'll let his head rest there, and I'll be focusing on, do I feel the narrowing and widening? He was still holding his head up, so not feeling anything other than his tension right now. And it might take patients a moment or two to finally settle in, let your head just sink back and rest. Are you comfortable?
Mm-hmm.
Good. So just rest, let your jaw be relaxed. Don't clench your teeth. Little space between your lips is great. If you feel the tip of your tongue, it should be behind your top 2 front teeth, just resting, and teeth should have a tiny little space between them. So that's a resting position of the jaw. It's a nice way to open up the cranium rather than having the jaw dropped open from having their head extended or slammed shut from having their head flexed. Now as I'm here, he's finally relaxed into my palms. He sees I'm not going to rip his head off, so he's letting go. And people are very protective of their heads, especially when they think you're trying to hold them up and you might drop them. Right? Oh, no, not going to drop you. And you start to feel that widening and narrowing. Now I feel on, what's your name?
Eric.
Eric. He has more of a widening phase, a greater amplitude. You guys are focusing on, gee, I want to just try to feel a motion here. Now I'm going to talk about not only do you want to feel the motion, but what is the amplitude of the motion. He has more motion on his right occiput, pushing out against my palm, than the left. And I'm going to feel that. And what do I feel about the symmetry? What do I feel about the energy behind the pulsation? Is it strong? Or is it very weak that I could barely perceive it? So his amplitude is greater on the right, meaning his range of motion, how far it expands into my hand and then narrows. But the left side on Eric seems to be stuck in extension. Doesn't widen as much. It's about 50% less widening that I could perceive. So I'll just wait. I let it widen. Now there's also a fast rhythm I feel of widening and narrowing. And if I'm watching his belly, that fast motion of widening up, that matches his diaphragm. So that's not his cranial rhythm. You have to differentiate between these two. So stop and watch and see for his breathing versus the slower rhythm of the craniosacral, 6 to 12 times a minute. Breathing 12 to 20 times a minute. Now I'm going to let him widen out all the way. Follow that motion just like a little kayak on a river with nobody in it. He's still widening. Even though he's breathing faster than that, he's still widening. And now we're going the other way. Now it's starting to narrow. So I'm following by just pulling my thenar eminences in as his head narrows. I'm following it and waiting. Inducing a still point. Follow the motion to the barrier. Induce a still point by locking my palms exactly where they are. So when his head starts pushing back against him, I'm not moving. Not because I'm pushing harder, but just because I'm using my intention to become an immovable force. Inducing a still point is what we call that. Now I don't feel anything moving. There's my still point. So I'll be waiting for about 1.5 minutes or 2 minutes. I could still feel his head moving from his breathing, and I could see it matches his breathing, but it's a lot faster than that little slow rhythm I was just monitoring with my palms. So especially in the beginning, look, listen, feel. Nothing's moving. This is a good time to have him practice his breathing exercise. Just kind of breathe into your lower belly, feel your legs getting heavy, arms getting heavy, everything relaxing.
Eyelids getting heavy.
That's good. His head's getting heavy too. That's the other thing. Make sure you have pillows and things so that you're not on hard tables. This is comfortable for me, but sometimes you're here for a while. So make sure you're comfortable. Still not moving. That's okay. His rhythm will start up whenever it's ready. Some people I've held these for a few minutes, not 90 seconds. Some people I've seen them release in a minute, but the average about 1.5 minutes, 2 minutes. Oh, there we go. Now the left side's starting to push out against my hand along with the right. And so I'm letting him move just by almost imperceptibly moving my hands out of the way. And he's staying in that widening phase a little longer than I thought he might. And we're just waiting. But where I didn't feel much movement on the left before, it was kind of like a balloon blew up and it pushed into my left hand. And I'm also feeling something interesting, a pulse. Sometimes you'll feel a therapeutic pulse. And that's as the fascia releases, there's a vasodilation because of that fibronectin we talked about way long ago this morning. There we go. Now we're widening nicely. And the rhythm's starting again. So I got a still point and a release. I'm going to feel what is the new motion path like. I feel more even between the left side and the right side, although the left is still a little behind. I feel more even, widening and narrowing on both sides. Remember, the occiput is one bone, so it's almost like it's pushing back into my hands and then moving away. Pushing back into my hands and moving away. Some people use just their fingers on the occiput like this. I personally get tired doing that. You could rest. However you want to hold that is okay, as long as your hands are comfortable and you're on the occiput, back of the occiput, okay, above the base of the skull, by the nuchal lines or a little below the nuchal lines. Okay, thank you so much. This is a different position for the sphenoid release. You saw me use my fingertips. Some people will just kind of cup the occiput under their hand and use their thumbs to do a compression, decompression of the sphenoid. That's fine too. You have both pictures in your book. You see what is comfortable for you. I could do my own sphenoid compression, decompression with my fingers right on my own sphenoid on my head. So these are things that you can teach. If a patient's good with their palpation, some of these things you can teach them. Easy on the ear pull and the mandibular release. Some of these other cranial techniques a little bit more advanced for them to do. But if you think they're good with something, they could certainly try. So just different hand positions. Give it a try. If you're finding it difficult to feel these rhythms, and these areas I'm showing you now are difficult to feel, that's okay. Ask the patient first to take some big breaths and notice what you feel as they take a large breath, 2 or 3 in a row. Then ask your patient, would you mind to hold your breath for me for a moment? Most people could hold their breath for 1 minute at least. Tell them, just hold your breath. Don't inhale and strain, but exhale and wait before you inhale again. Because now there's no other movement except the cardiac pulse. So there is an opportunity to feel the cranial pulse. And this is my baby. Note the resemblance. Akita, yes, Sachi. She loves cranial. Some years ago, we were horrified that she escaped out of the house at Christmas Eve and got hit by a car. And she didn't even recognize me when I found her. And what was I doing on her? Cranial. Craniosacral. She's fine. She loves a good run. So that's the Sachmeister. So we're going to do a sacral release next. And again, you have this picture in the book. Do you have to have your hands in that position? Absolutely not. However you choose to hold the sacrum and cup the sacrum in your palm, perfectly fine. This is just an example. I could do this in prone, supine, side-lying, hanging from the chandeliers if it worked. Okay. So comfy patient. She has some trouble. You mentioned you have some sacroiliac trouble you mentioned. Any problem putting pressure on here? Okay. So she can have all kinds of dysfunctions of the sacroiliac joint. I have a whole 16-hour course just on that if you want to go on and on. But one of my favorite things to do, despite the fact that I could spend 16 hours talking about it, this particular release I find works better than all the other muscle energy stuff that I spend 16 hours on. This I could spend 2 minutes on. So it's one of my favorite things to do. Many people get compressed at the lumbosacral junction. We sit too long. We stand too long. We're always in that compressive mode. You know, how much time do we spend moving in all different directions? We spend more time moving forward. So people get a lot of pressure, a lot of back pain back here, and you may find that this sacral release is very helpful for that. I mentioned earlier that the durumata of the cranium and is completely continuous through the spinal cord. It's firmly attached at S2, S4, okay, through the filum terminale. So whether you're pulling on the dural tube from up here at the occiput, foramen magnum, or pulling on it from the sacrum using your craniosacral releases, either way you can get a great release. I like to do a separate sacral release to kind of decompress that lumbosacral junction, and this is also related to some of that pelvic floor as well. Some of those pelvic floor fascias attach into the sacrum and inside the pelvic bowl. This is also a nice release for that. How you rest your hand on the sacrum. If you can't see through her clothes or feel where the sacrum is, okay, I'm just going to touch your waist here. Find where the waist is, narrowest part of the waist, iliac crest. Follow that in. Okay, that's usually level with L4. Next bump down L5 and then the sacrum. If you can see, and I generally work directly on the skin for patients, you'll see the 2 little dimples here. That's around where that posterior superior iliac spine is. Come to the middle of that. I'll rest my hand right on the sacrum. Now for patients who are a little bit more private, I let them know immediately I said, I know you have some back pain, you have some sacroiliac pain, I need to put a hand on your sacral bone, between your cheek here. Is that okay? Because some people want to know why my hand's on their bottom. So you let them know exactly what you're doing. I can have my hand in the same position with her supine and my palm underneath her. But if I did that, you wouldn't see my palm. So I can have her sideline. I might choose to hold the sacrum this way. I might have decided, oh, this hand's tired, I'm going to use this hand. Sometimes I rest two hands on there. It's entirely up to you as long as you can palpate the movement of the sacrum. Most of you are more sensitive with your dominant arm. I train myself to be sensitive with both. So if I was right-handed, I might decide, let me just feel with the right hand. So what motions do I feel here? We're back to the breathing. Take some nice deep breaths into your belly. I want to feel the motion of the body from the respiratory rhythm. That's faster. Everything's lifting up. But it's lifting up together. The craniosacral rhythm palpable at the sacrum is basically and imagine if my palm is the sacral base is at the superior aspect, the coccyx or tailbone at the inferior aspect, so sacral flexion and extension is almost like a rocking motion. Feels like the sacral base goes in, moves away from you, tailbone sticks out. That's called sacral extension. If the tailbone tucks under and the base becomes prominent, okay, that's flexion. I like to think of when an animal is fearful, I'm thinking of the fearful as an F and flexion as an F. When an animal is fearful, what do they do with their tailbone? They tuck it in. They tuck their tail in. So flexion when they're fearful. If that helps you remember what's flexion extension, it's a good thing. So I'm going to rest my hand here. And now the breathing, I feel like the whole sacrum moves up and down. The craniosacral rhythm, the sacrum is rocking in this position. And you can feel that. The rocking of the sacrum often matches the rocking that you might have felt during their postural sway evaluation that we did earlier. Many times people who have problems with the sacroiliac joint or low back have more of an AP, anterior-posterior sway, because the rocking here may be excessive or diminished. So just rest my hand on there. You okay with that, comfy? You good? And when do I feel that top of the sacrum moving into my palm heel? When do I feel that tailbone moving away? That's flexion. When do I feel the opposite? That's extension. Now, if you're having trouble feeling it, okay, what can I ask her to do? If you can wait on your breathing for a moment, like next time you exhale, see if you could spend several seconds before you inhale again. I'm trying to feel a little motion here. Sometimes the breathing is just too confusing, and that will help. You don't actually have to do that, but with a patient, that will help you on any of these releases to sense what's going on. Okay, so here she's going into extension. Sacral base is moving away from me or anteriorly. So sacral base moves anteriorly, extension. Tailbone starts to move posteriorly. And waiting. When the motion comes back the other way, you're just going to follow it. Not coming back yet. So follow that motion. There it goes. So when shifts, I'm a kayak on a river just floating along, going wherever the current takes me. So if the current's rocking this way, I'm going to follow it. Okay, extension. It's rocking this way, flexion. Extension, flexion. So you're going to palpate to feel that relative rocking motion of the sacrum. It feels like it's through the middle transverse axis of the sacrum. There's actually several axes in the sacrum, but middle transverse is most palpable here. And follow that motion to an end point. Some people stay extended most of the time. Some people stay flexed most of the time. For her, she's more extended. So I'm just going to follow. Hold that. So extended means the sacral base is moving anteriorly or getting deeper. Sacral apex, the tailbone, becoming more prominent. I'll follow that. And next time it tries to go the other direction, I'm simply locking my hand in, inducing a still point. Freezing myself with my intention, not with my force, but with my intention. And just holding. You okay with that pressure there? How much pressure would you say I'm placing on you? Light, medium, or deep? Light. light to medium, depending on the body size. I have a patient who's a bariatric patient. To feel through those layers of adipose tissue, can you imagine I'm moving a little bit with more force? I have somebody who's elderly, very osteoporotic. How much pressure do you think I'm using on her with the thin skin and the brittle bones? Light. So the pressures can be changed, and now I'm feeling a little change of that still point. Feels like the sacrum's tipping to the right. There's many different motions of the sacrum, so those are things you could learn about with muscle energy, mobilization courses. Still tipping to the right. Can you feel anything or no? Just feel me moving on her. And many patients go, I don't feel anything. That's okay. Follow it to an end point, hold it through the still point, wait for a new motion path. It's the same thing that we're doing all afternoon with these craniosacral releases. Follow it to an end point. When you feel that rhythm starting again, try to assess what is the new pattern like. Did the tissue take a new motion path? If so, once that rhythm starts again, gently withdraw. And we're going to complete this. Typically I don't do the sacrum alone, but I could do a craniosacral balancing. So one hand on the occiput, one hand on the sacrum, whatever direction you want your hand, make it comfortable. And just like the other things before, we're going to rest our hands, but we're going to see, can we coordinate the motion between the sacrum and the occiput. So we said that flexion at the occiput is a widening feeling. Flexion at the sacrum is like the tailbone's tucking under. I want those occurring together simultaneously. I want a balancing of the craniosacral rhythm. What are you feeling? The push of the CSF as it's going down through the spinal cord, caused by the production of CSF in the choroid plexus of the brain, causing that widening or expansion of the ventricles, which you could palpate in the cranial bones. I could palpate that all the way down to the sacrum. So I'd have a hand on the cranium, hand on the sacrum, feel for the motion simultaneously, and then induce a still point under both of your hands. That's a little challenge when you're first starting to do this. I tend to focus a little bit more on one hand first and then the other and try to time them together. So she's actually in a narrowing phase here, which is just she likes to be an extension more so than flexion, the cranial system. So I'm going to follow those two together. Narrowing phase. When it gets to its narrowest phase, I'm going to lock it in, induce a still point by preventing the widening sensation. Just freezing my hand in and holding. Waiting for a still point, inducing that still point, waiting for the motion to begin again. That's our craniosacral balancing. Now, if you do quite a bit of craniosacral work on patients, especially if you are not sure of what you're doing just yet, it's easy to imbalance them by putting tension across membranes, and sometimes people feel a little off balance, kind of like saying, gee, I stretched one half the patient's body but not the other half. How do they feel now that they get up and walk around? They feel a little off kilter. So if you finish a craniosacral session with a craniosacral balancing, you balance that out. So they don't feel weird. Some people feel a little flighty or a little foggy. When they first get up, they're all relaxed. They're used to being in high tension state. So this is a nice way to get them kind of grounded and have them breathe, relax. It's a nice way to do it. I could do this in sideline. Picture in your book is shown in sideline. I've done it on patients in sitting plenty of times. Supine, but they tend to crunch your hands a little bit in the supine position. It's certainly an option. So let's go ahead and check out the sacrum motions on our partner. Let's check out the cranium separately, the occiput, and then the two together. See if you could balance out your partners, and we'll talk a little bit about the research. And take some deep breaths. Make sure when patients get up, they get up slowly, they take some deep breaths, they kind of gather themselves. I usually have them do some kind of closed kinetic chain activity to help them get used to their new motion. Thank you. I'm going to show you some of the studies that are out there. And again, you don't have to take notes. You have these in your bibliography. This is a study looking at effect of craniosacral therapy, often called CST, on carpal tunnel syndrome. So Norvikash and Arab did a study called The Effects of Oscillating Energy Manual Therapy on Symptoms Associated with Carpal Tunnel Syndrome. Randomized, double-blinded, placebo-controlled study from 2012. 14 subjects with carpal tunnel, these little annotated bibliographies here, randomized to treatment group versus placebo. They did 6 sessions of craniosacral therapy to the transverse ligament, Now, if you remember with carpal tunnel, your transverse carpal ligament here coming right over that carpal tunnel, that's often one of the things they resect surgically to take the pressure off median nerve, because as you know, carpal tunnel syndrome is median nerve compression neuropathy. So what they did was craniosacral therapy to the transverse ligament and the radial artery. So they were thinking about how can we open up circulation to this area. They had a statistically significant difference in night pain, resting pain level, and also functional level. So they did a number of different tests and they found a difference. Now they're calling, there's a version of craniosacral therapy called oscillating energy. They chose to call it that, where we actually place our fingers, Upledger called it a V-spread technique. I didn't teach it today, but it works the same way. You put your fingers across that area where there's abnormal tension and wait for the still point. There's a little subtle motion there, wait for the still point. When that happens, releases the tension. Interesting that for a double-blinded placebo-controlled study that they got a nice result like that. Effective carpal tunnel syndrome on lateral epicondylitis. One of the same researchers with a different partner this time, Norbakash and Fearon. Effective oscillating energy manual therapy on lateral epicondylitis. Another randomized, double-blinded, placebo-controlled studies. Okay, Journal of Hand Therapy, this is from 2008. They looked at different variables, pain, grip strength, and functional abilities of people with that chronic lateral epicondylitis, that tennis elbow. A number of subjects is 23 with chronic lateral epicondylitis, LE, greater than 3 months, ages 24 to 72. They did 6 sessions. This is very typical of what we're seeing with managed care today. Oxford allowed you 6 sessions to treat that rotator cuff repair. You're getting a very limited deal when it comes to interaction with your patients. Randomized into a treatment and a control group, and they tested pre and post treatment, and they also tested their outcome 6 months later. Because one of the common questions is, okay, gee, they felt good now, but what's the carryover? Did you see any carryover? Statistically significant improvement in grip strength, so using like a JMAR hand grip dynamometer, and I gave you the P level 0.03, pain intensity, function, and also limited activity due to pain. So they looked at a number of functional scales, and very nice to see the difference. This, of course, they were doing the same what they call the V-spread technique, inducing a still point, but this time it was over the lateral epicondyle. The placebo was actually to put the hands in the same position, but they weren't inducing any still points. So very different in terms of the intention. What happened later? 91% maintained their improvement in function. Now, I don't often see that with something as chronic as lateral epicondylitis. People go out doing the same gripping, doing things the wrong way, repeating their irritation. 73% remained pain-free for at least 6 months. And I gave you some links where you could access this. These are all published through the Fascia Research Congress. Craniosacral therapy helping fibromyalgia pain. Here's an issue where people with fibromyalgia have a lot of trouble, and we often find we're not very adept at treating this. Castro-Sanchez et al. Did a randomized controlled trial. Again, we're looking at good levels of clinical research, not just case reports. Effects of craniosacral on pain and heart rate variability. Interesting, what's happening with the sympathetic nervous system in fibromyalgia patients. A Clinical Rehabilitation Journal, 2011, so these are pretty recent. 92 patients with FMS, fibromyalgia syndrome, randomized, treatment and placebo. They had 20 weeks. Now, I don't see any insurance company giving anybody 20 weeks of therapy these days, but wow, that was pretty good of craniosacral therapy. They measured heart rate variability, which is using Holter monitor, and blood pressure. And pain levels, what do we get? Statistically significant difference in pain, okay, in 13 out of 18 of their trigger points. Now, typically, one of the definitions for fibromyalgia is that they have pain in at least 11 of 18 trigger points. Here they got 13 of them improved in their pain difference. Here's your p-value. And one of the measures of heart rate variability, temporal standard deviation, okay, that's a bunch of stuff. Basically said the sympathetic system responded better. Okay, they also did a clinical global impression of improvement versus baseline. They did another follow-up also at 2 months and 12 months. Continued significant difference with the treatment group. So, and they listed some of the points that had improved. So it's nice to see that something actually has a carryover some months later. We don't see that on a lot of previous studies where they were able to get those subjects later on. Here's another study looking at craniosacral therapy alters cranial membrane length. And this is Dr. Dimitrios Kostopoulos. He's actually a physical therapist in my area of Queens, right in the area where I grew up. He studied changes in elongation of the dural membranes of the brain. Naturally, this is done in cadavers during application of some of these craniosacral therapy techniques. So they used embalmed cadavers and they measured with strain gauges. What's the elongation of the falx cerebri? Okay, there's different releases that you do for each of these falx cerebri, falx cerebelli. We didn't go over each of these, but there's more techniques you could learn taking other cranial courses. How much motion? 1.4 millimeters for the frontal lift. Oh, look, we did that. 1.08 millimeters for the parietal lift. So you can actually measure the movement of the actual cranial membranes. And this was done here. Sphenobasilar compression. Oh, we did that. Minus 3.3. What are we doing? Taking the pressure off. So it's a negative. Sphenobasilar decompression, 0.28 millimeters. Okay, so not a lot of movement there, but measurable movement. Very interesting. For the ear pull, they didn't get conclusive results. I don't really know why. Okay, and present study offers validation for the scientific basis of craniosacral therapy, which is that we are claiming we're removing these membranes to adjust tension in the membranes. And here he's actually measured that movement. This is in the journal Cranio. Another one, myofascial release and osteopathic manipulation. Interesting, different group of people. Children with moderate to severe cerebral palsy. Look at the range of ages here. 20 months to 12 years. Look at the levels of developmental variability across those ages. Number of subjects in the study is 55. They did a few different variables here. Osteopathic manipulation, which is basically grade 5 manipulations in the spine, with and without myofascial release. Myofascial release alone. Another group got acupuncture alone, and then finally, of course, a control group. In the 11 outcome measures, they had a significant improvement in the gross motor function measurement for children and the functional independence measure for children. And these are standardized, valid, and reliable functional tools used. And if you think about how easy is it to treat kids who have moderate to severe cerebral palsy, think of the levels of spasticity they have, and we're seeing changes in their functional independence using these techniques. So that's pretty exciting. That was in the manipulation group, with and without myofascial, myofascial alone, not in the acupuncture group, and not in the control group. Here's another one post-surgery. This is of special interest, especially to speech therapists. Marsalek and his group looked at mean esophageal pressure in patients who had laryngectomy. These people who had cancer of the larynx, they had laryngeal surgery, and something that happens with these surgeries is the pressure in the esophagus becomes very strong. It makes it hard with the scar tissue for them to relearn how to speak again. What did they find? They took a group, did myofascial release. Of course, the control group, no myofascial release. And interesting, what did they do myofascial to? Most people would think just the scar tissue. Not just the scar tissue, but upper neck, head, trunk, arms, all of this area was related. Connects through the fascia. And the people who got the myofascial had a significant decrease in mean esophageal pressure and also were able to relearn how to speak sooner than those who didn't have the myofascial. I mean, imagine how debilitating you might feel if you couldn't express yourself. And if there's a technique that could help you relearn how to speak again after having such a tremendous surgery. A myofascial trigger point. Anderson et al. did a kind of low level of clinical research, but interesting case studies of 138 patients with chronic pelvic pain, prostatitis. Typically, docs tell these people, yeah, you have this problem. I know you're having trouble controlling your bladder. You know what? Wear a diaper. That's the way it goes. You got to live like that. And it's a shame because many of these people just let go. There's a whole area of rehabilitation, pelvic floor rehabilitation, that's now done to address these issues. They did a study here taking these people with the chronic pain using myofascial release combined with trigger point. Trigger point is basically ischemic compression held on the trigger point. Paradoxical release is a specific contraction and relaxation of the muscles, in this case around the sphincters. They had improvement in 72% of the cases. So that's huge considering most of these people have improvement in no cases because you're just told to live with it. They did a pelvic pain symptom survey. Half these people had 25% less pain on that symptom survey in as little as 5 sessions. So I like when I see things like this, that things can happen in just a few sessions because many people don't have insurance coverage to be coming for 20 sessions, 30 sessions. So that wraps up our research. There's plenty more out there. You can YouTube videos from the Fascia Research Congress that show you some of the presentations, and it's certainly free to access. You could take a look. Let's just throw in another one. Okay, Arroyo Morales did a randomized clinical study comparing. Now this is an issue with literature. Often myofascial is called massage, and massage is called myofascial. So they mix these techniques up. They're basically manual therapies. They took 62 people, had them ride like crazy on bicycles, trying to induce some level of exercise damage. And they measured different variables. They measured how much did the muscles relax 40 minutes after the high intensity cycling. That's with surface EMGs, SEMGs. They also measured heart rate variability using, again, Holter monitor and blood pressure, saying what is the sympathetic nervous system doing? Well, lower sympathetic tone in the group that had myofascial/massage had much less tension in their muscles, as demonstrated by surface EMGs, electromyograms, and also a better heart rate variability and blood pressure response was more favorable in the treatment group. So we're seeing responses not just to muscles to relax, but think about the autonomic nervous system. Multiple systems involved. Here's some more. Repetitive motion strain. This is modeled in a lab. They're not using people, they're using cells that build fascia. So Meltzer et al. Is doing a lot of studies with modeled repetitive motion strain in vitro, so in a lab with myofascial release using human fibroblast cultures. And they submitted these cultures to different levels of strain. 3 groups, 8 hours of repetitive motion strain alone, myofascial release for 60 seconds. Interesting, they did 60 because most of us have been doing for 60 years or so in the field, 90. And then a combination, repetitive motion strain and myofascial. What's the results? Due to strain, there's immediate change in the cell shape and structure, morphological changes that can be noted as a result of repetitive strain. What are those changes? Increased apoptosis rates. What does that mean? They die sooner. How do you know? Because there's certain chemicals produced by cells that are being strained repetitively in response to that trauma. FAK, focal adhesion kinase. That's a chemical related to, remember we said things stick together? Collagen cross-links. FAK. DAPK, this sounds nasty, death-associated protein kinase signaling. Cells are dying sooner when they're subjected to repetitive strain. Guess what? This was not seen in the group that had myofascial release, and even more interesting, not seen in the group that had repetitive strain, but was also treated with myofascial release for a mere 60 seconds. You didn't see those cells die as readily. So this is very interesting stuff. This is Journal of Bodywork and Movement Therapy. That's 2010. Earlier I told you we could see trigger points and changes in cellular structure, changes in fascial density of the collagen proteins. You could see it on ultrasound. So Paul did a special type of high resolution, high frequency ultrasound, and went subcutaneously to see in 10 cases. What happens when you compare a normal area, in this case of the back, to a restricted area? Well, the restricted areas show up as increased hypoecho on the ultrasound, and increased density, looks like white, thick, dense tissue on the ultrasound. After they did myofascial release, skin rolling, skin pressing, basically taking up the slack and holding, change of collagen density, reduced the dermal densifications, and relaxed, or again, changed the shape of the fibroblast. We noticed from the other study that we said there's a morphological change in the fibroblast where they got stretched out, they became abnormal in their cell shape, and cells can't function in an abnormal shape. This normalized some of the very cells that build fascia. So we see that in a lab as well. Reduction of inflammatory agents, I mentioned this morning. Crane took a bunch of crazy athletes and said, let's really see what we could do about wrecking your quads. And they had them do isokinetics. Work those quads, work those quads. And they did a nice biopsy of the vastus lateralis before and after to see what kind of problems happen when we induce exercise in the muscles, what kind of damage happens. And then can we take 2 different situations, massage one group of these people doing heavy exercise, and have a control group that doesn't get anything. So 11 males volunteered to biopsy the vastus lateralis at rest, and then they checked it also immediately after massage for 10 minutes worth of time, and 2.5 hours later after exercise. What did they find? No effect on lactate and glycogen. And we always hear these studies how, oh, the lactate, the lactic acid, that's what's making you sore. But they're not seeing any change in that, which is interesting. But what did they see change? Inflammatory cytokines were reduced in the group that got massage or myofascial release. What are those inflammatory cytokines they measured? Tumor necrosis factor alpha, interleukin 6, and HSP27. So a lot of these studies are now being done looking at the biochemical changes in response to the hands-on work that we're doing. And that's kind of exciting to see. I mentioned again to review those acupuncture meridians, the areas of the fascial planes of the body, where one layer of fascia meets another, those layers need to glide past each other. If they have abnormal tension, myofascial restriction, sticks together. We call that collagen crosslinks. What do these people do? They measured electrical impedance in 28 healthy people across the skin and subcutaneously and found a positive correlation between the fascial planes of the body having changes of electrical conduction and the acupuncture channels. And fascial planes have a very high correlation with where the acupuncture channels or connecting the dots of those acupuncture meridians are. So very interesting. In my office, I use a trigger point finder, and I can actually measure the difference in electrical conductance across these fascial planes, and anybody here licensed to use electrotherapy or biofeedback can certainly do that right in your office. Helen Langevin, this is a little long-winded, but I'll just put it in a nutshell. Helen Langevin's a medical doctor that's been doing myofascial research for like 20-something years. She's well known out there in the field for all the crazy stuff she does with her mice. And one of the studies, she showed that the fibroblasts, the cells that build fascia, subjected to stretching, subjected to strain, change their shape. So this is modeling what we had in some of the other slides. There's a morphological change as a result of strain. And what does that mean? That means that the cells, what this means in English, the cells that build fascia are responsible for the viscoelastic properties of the tissue. Many times we think the tone of the muscles, the tension we feel in the body is just monitored by the nervous system. And we talk about like spasticity, we talk about tone, but the tension in the tissues, the density of the tissues is actually determined by its viscoelastic nature, which is determined by the shape of the fibroblasts. And the shape of those fibroblasts that build fascia responds differently to different levels of strain. And she's also subjecting these cells to all different pharmacological agents to see, what medications might help that strain condition, what medications won't. So we're going to see some new information coming out from Dr. Langevin. But basically, she's saying the matrix tension, the ground substance in the fascia, is really what's determining some of the tension we're perceiving in those patients, and of course what they're perceiving in themselves. You guys covered a lot of ground. I wanted to congratulate you on getting quite a bit done. I saw some very nice hand positioning. I know that not everyone felt all of the changes. Not everyone could perceive it, and certainly not in every single technique. We didn't expect that you would get all of that today. But I do expect that at least you know hand positions that you could try to use and start to perceive some of the subtle tensions in the myofascial system, the fascia of the craniosacral system, and you can start to learn how to interact with that by learning to induce a still point. Identify the motion path, follow it. Find the barrier to the motion path as it goes through a cycle of mobility. Lock in your hands and freeze it, induce a still point at one end of that cycle. Everything gets quiet for that minute and a half, 2 minutes, sometimes several minutes on a patient, and wait for that motion to start again. That is the release, the myofascial release, the craniosacral release. Allow that motion and assess, how is it now? What's changed? The critical element in our field of rehabilitation is to assess, is there a functional outcome that's changed, something that we've measured before we saw the patient versus something that we're now measuring after. So get those functional outcome tools. Just so you know, there's a physical therapist named Carol Lewis who wrote the Functional Toolbox. You might have heard of her. She is being an advisor to our National Institute of Health, and she is a key person that's helping them decide what you need to write for functional outcomes on those insurance forms. Mandatory in U.S. government, mandatory in any federal level insurance like Medicare, July 1st of this year. So something worth your looking at. And remember, you have the pictures of everything in your book. There's also a little exam that was in the book. You don't have to take the exam, but there is a course evaluation. If you'd be so kind, please, to fill out that course evaluation. It's a loose add-in with your book, and please hand it in at the front desk. Thank you very much for attending the evidence-based myofascial and craniosacral, and I hope you enjoy doing the work and making a difference with your patients. God bless you. Thank you.